Hello, 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 everybody. Welcome, welcome, welcome. Tonight, our guest is Dr. Christian Hanna, a pediatric nephrologist on PKD on children. Dr. Hanna is a member of the Pediatric Nephrology and Hypertension Division at the Mayo Clinic in Rochester, Minnesota. He also has a joint appointment in the Division of Nephrology and Hypertension Department of Internal Medicine at the Mayo Clinic. His areas of expertise and interest include pediatric cystic kidney disease, including autosomal dominant polycystic kidney disease, or ADPKD, autosomal recessive polycystic kidney disease, or ARPKD, and other causes of cystic kidney disease in children and adolescents. He is a member of the Mayo Translational Polycystic Kidney Disease PKD Center and the medical director of the Mayo Clinic's Pediatric Cystic Kidney Disease Clinic, which provides comprehensive care to pediatric patients with cystic disease. Dr. Hanna also conducts research studies and clinical trials to discover promising biomarkers for disease prevention and evaluate new treatments for cystic kidney disease. He became an MD in 2006 at the University of Damascus, where he earned the Medical School Dean Excellency Award. In 2010, he completed his residency in pediatrics at the Southern University of New York at the Upstate Medical Center. In 2013, he completed both his Master's of Science and Clinical Investigation and his fellowship in pediatric nephrology at Northwestern University in Chicago. He is board certified by the American Board of Pediatrics in both pediatric nephrology and pediatrics. He is a member of many, many professional groups, including Polycystic Kidney Disease Foundation, the PKD Research Resource Consortium, Pediatric Research Committee at the Mayo Clinic, the American Society of Pediatric Nephrology, ASPN, and its Communication Committee, Pediatric Nephrology Research Consortium, PNRC, the American Society of Nephrology, the International Society of Pediatric Nephrology, the International Society of Nephrology, the American Board of Pediatrics, and the American Academy of Pediatrics. He has written extensively in numerous professional journals, and he is an award-winning physician, instructor, author, and researcher. Please give a warm welcome to Dr. Christian Hanna. Doc, how are you doing tonight?
Hi, Jim. How are you? Thank you for having me on your show. How are you today?
I'm doing very well, thank you.
Good. Thank you. Thank you.
If I can get to the questions here. Tell us, Doctor, did I get everything right in the introduction?
Yeah, thank you so much. That was a very nice introduction, and from a person like you who run the podcast about ADPKD and a member of many advocacy foundations, that was a very neat presentation and introduction. So thank you so much.
Tell us a little bit about where you grew up, your education, and your employment experience.
Thank you so much, Jim. So I came to the United States in 2007. I'm originally from Syria. It's a country in the Middle East, at the Mediterranean Sea, where surrounding by other countries, Iraq, Israel, Jordan, and Palestine, and Turkey. So I did my residency in upstate New York. Then my passion in pediatric nephrology started during my residency. And in fact, my graduation thesis in Syria was about inherited cystic kidney disease in children. And I did my fellowship at Northwestern in Chicago. And then I moved to the Minnesota, and I spent a few years at a different medical center until I joined Mayo end of 2019. And I've been with Mayo Clinic for the past 3 years.
Okay. I want to ask you some questions tonight about pediatric kidney patients and ARPKD, PKD. Your recent article in the summer edition of PKD Life, I'm holding it up here, about the dilemma in screening concerning children of a parent with ADPKD, and should screening for PKD take place with these subjects. Are you comfortable in terms of your expertise in speaking about these subjects?
Yes, yes, Jim. Thank you so much.
Christian, please briefly describe for us, what is polycystic kidney disease?
So polycystic kidney disease come from the word, so a disease of the kidney related to multiple cysts. So poly means multiple, and these cysts usually involve both kidneys. Rarely you can have one kidney with many cysts and other kidney with none or few cysts. So this is what they call it, polycystic kidney disease. And it's and the term polycystic kidney disease is divided into two diseases: the autosomal dominant polycystic kidney disease, which used to be called the adult onset polycystic kidney disease, and the autosomal recessive polycystic kidney disease, and used to be called the infantile polycystic kidney disease. So these are the main two causes of PKD. However, we've been discovering other genes, Mayo Clinic with collaboration of other centers in the United States and Europe. We've been discovering other genes in the last few years that can cause polycystic kidney disease, and usually the presentation of these patients is mild. And the reason why we're not calling it anymore autosomal adult or infantile onset, because they can overlap. You can have a severe adult onset polycystic kidney disease, autosomal polycystic kidney disease in children, while you can have a mild infantile autosomal recessive polycystic kidney disease in children, and that can survive into adulthood.
Okay, let's talk for a minute about autosomal recessive polycystic kidney disease, or AR PKD.
Yes.
The PKD Foundation tells us that it's a rare genetic disorder occurring in approximately 1 of 25,000 children. It affects boys and girls equally and can cause death in the first month of life. If an ARPKD newborn survives that period, the chances of survival are pretty good. For these children, approximately 1/3 will need dialysis or transplantation by the age of 10. In general, would you agree with that assessment?
Yes, that's historically the natural history of ARPKD, definitely.
If I'm the parent of a newborn child that has ARPKD within the first month of his life, what can I expect?
Okay. So regarding ARPKD and why it's rarer than the ADPKD, the autosomal dominant, because in order to get ARPKD, you have to have a carrier parents. The dad and the mom have to carry the defective gene and transmit it to their children. And usually ARPKD is not as known as ADPKD because none of the parents have the disease. Other than ADPKD, as you know, it can be transmitted through family members. So the dad have it, the grandfather has it, and brother and sibling, cousins, usually in 90% of the cases. When family member parents heard the term ARPKD, it's come to them as a shock because none of the family member, their cousins, uncles, or family, none of them have this condition. It's a condition that dad and mom, they got married, and each one of them have the gene. So the condition can be diagnosed prenatally. And that diagnosis can be a non-specific presentation. Usually, the kidneys will look large, they will look more brighter, and sometimes in severe condition, when the kidney does not work in utero, they don't produce urine. And as we know, the amniotic fluid, that the fluid surrounding the baby to make them grow and make the lung develop, it's primarily made by the urine after the 20 weeks gestation. So if you don't have a kidney function or severe kidney failure in utero, you will not make amniotic fluid. And if you don't make amniotic fluid, that to lead to underdevelopment of the lungs. So the reason why patients with ARPKD, the severe form, they don't survive, not because of their kidney failure, it's because of complication of kidney failure, which is underdevelopment of the lungs. So they born and they don't have a lung tissue, or the lung is severely diminished in function, so they cannot survive. So this is what we call the severe form of ARPKD. The majority, some of the patients, or quite patient, can survive this critical area and move on during their childhood, and they can reach adulthood as well.
Okay, I have read that almost 80% of the ARPKD children will survive the newborn period. Is that a statement you would agree with?
Yes, and based on in a literature review and my own experience in a database that we're collecting now at Mayo Clinic, we've seen that the majority of children who are surviving the newborn period, they will eventually go into a kidney failure needing a kidney transplant, but some of them, we're finding some of them, they're reaching their adulthood or adolescence and they don't yet got a kidney transplant. So it's not when you mention ARPKD, doesn't mean that the survival after birth is down to zero. No, there are patients who survive that childhood, and it's and that they can get into adulthood as well.
Okay. Is it fair for me to say then that previously ARPKD was thought to be a fatal disease, but prognosis has dramatically improved? As you mentioned, about 90% survive to their 20th birthday, and 50% of those survivors at that point don't require dialysis or transplantation. Is that correct?
Yeah, that's correct. And the reason why I don't think we can control the change of the genes. I think regardless of what year we are at, I think the prevalence of complications or the expected complication would be the same. But what are we doing to prevent this complication or to manage this complication have changed dramatically. And let's talk about the prenatal period. Nowadays, there are centers in the United States, including Mayo Clinic. If you have severe kidney failure during pregnancy, that they don't have amniotic fluid, there are centers, including Mayo Clinic, they can enroll these patients in a research study where they infuse artificial type of amniotic fluid to let their lungs develop, and then after birth, they can survive because we were able to develop their lungs. Number two, if these patients survived, over the last decade or so, a tremendous advancement happened in the way of managing end-stage kidney disease in these children, in a way of developing a machine that can be pediatric friendly, like a dialysis machine. Actually, in 2020, the United States have approved the FDA have approved the first dialysis machine for children between 2.5 and 10 kilos. And let me translate the 2.5 to 10 kilos, between 5 pounds and 22 pounds. And this was approved in 2020. This has been used in Europe since 2014, but in the United States, it's been approved since 2020. And also the other type of dialysis, the peritoneal dialysis, there's been advancement of creating a catheter or peritoneal dialysis catheter that could be a pediatric friendly. In addition to having a multidisciplinary team approach and having a dedicated children's hospital and center around the United States, that led to improvement of survivors of these patients.
Okay. Can you tell us what is the average life expectancy for a child born with ARPKD that survives the newborn period?
For the patient who survived the newborn period, I cannot specify numbers, but I can tell you that the patient who survived the newborn period, they're they're um, they're surviving the critical period. That's mean they have a lungs that developed. They may eventually get into a kidney transplant, and the survival of end-stage kidney disease in pediatric ARPKD is lower than the general population. And also, pediatric kidney transplantation survival rate, although it can come closer to the general population, but it's not as the general population. In addition to kidney problem with patient with ARPKD, they can have liver problem. So we need to uh, discuss the liver disease. Some of their liver disease can be severe enough that they require a liver transplant. And actually, we've seen cases in pediatric they require combined kidney and um, a liver transplantations. They can have inflammation of their biliary tract, which is the biliary tract is the duct inside the liver. They can be dilated and they can lead to what we call cholangitis, inflammation of the biliary duct, which can be sometimes problematic and lethal if it's not addressed appropriately. So ARPKD is not only a cystic kidney disease. It can involve the liver, the biliary duct in the liver, and that can lead to complications. We've seen cases, and there it's been reported there are adults who presented with ARPKD. There's a few number of patients who are not diagnosed during childhood. They have a normal childhood, and then after their 18, 20s, in their 30 or 40, they can present with the first manifestation of their RPKD. And this is usually a liver complication. They can have liver cirrhosis, or they can have portal hypertension, can lead to GI bleeding. They can have infection in the biliary tract, while they will have a mild to no kidney disease. So as you know, the ARPKD is not is not a homogeneous disease. It's a heterogeneous disease. You can have prenatal diagnosis, or you can have normal adult that have a mild disease or severe disease presented during adulthood.
In terms of life expectancy, does it make a difference whether ARPKD is discovered before birth or after birth?
Yes, if there is ARPKD developed before birth, that the expectation, if there is no intervention into it to make the lung survive, and it was a severe disease, complication can happen after birth, because these patients will be on a ventilator. They can have a severe lung disease, and if they're not a lung survivor, they will not survive. If they survive and they're able to breathe on their own, or with the help with a ventilator, or maybe a help with the tracheostomy, they will have a severe kidney disease, and they may not survive because of complication of their kidney disease, complication of dialysis, or inability to get access to kidney transplantation. So yeah, the more severe the kidney presentation of ARPKD, the higher chance of decreased survival.
Okay. What causes ARPKD? Why does this happen?
Yeah, it's a gene called PKHD1. It's different than the PKD1 and PKD2 gene that's known to cause ADPKD. And that gene is expressed in the kidneys, expressed in the liver and the biliary tract. So if you have a knockout of the gene, and that gene defect come from dad or mom, that will lead to developing of a small kidney cyst, a large echogenic kidneys, with early onset ARPKD. In the liver, it can lead to fibrosis of the liver, or what we call it cirrhosis. And when you have a liver disease or end-stage liver disease, that lead to complication in terms of portal hypertension, bleeding into the esophagus, large spleen, platelet count will be low, they will have anemia, and they will prone to infection. So this gene is expressed in every single in the kidney and the liver mainly, and a mutation of the gene this can lead to these complications. And that gene has to come from dad and mom. So the child or the person who have the ARPKD have to inherit one gene from dad and one gene from mom, and they have to have the defective gene in both part of the chromosome to cause the disease. Why parents, each one have one gene each, they usually don't have any symptoms.
Okay. You've talked to us about parents that are affected, parents that are unaffected. Talk
Yes.
to us about uh, children that end up being carriers. How does that work?
Okay. So I wish I have a board I can write on, but let's assume a child have ARPKD. That's mean the father who have two gene, who have two chromosome, one of the chromosome carries the abnormal gene, and the mom also have two chromosome, one of these chromosome carry the abnormal gene. So in order to get one defective gene from dad and one defective gene from mom into the child, that's a chance of 25%. The chance of any child to be a carrier is 50%, and the chance of having a child does not have the gene that's mutated is 25%. So when we talk about parents who have everyone carry the gene, we tell them you have a 25% to have a child with ARPKD, a 25% to have a child who have no mutation, and a 50% to have child who have a carrier of the gene. And then the family asked me, so how does it look like for our child who's carrying the gene? Um, we usually tell them they usually don't have any symptoms as a carrier. And in order to have children with ARPKD, they have to marry another person who's a carrier of that gene. And this is very rare to happen, as you know, because this condition is one of 25,000. To have somebody carrier of the gene marry another person carrier of the gene, this is rare, and this is what make the condition rare. 1 out of 25,000.
Okay. Little shout out to a couple of friends of the show, Elizabeth Son, and my friend Bobby has anticipated my very next question. How is ARPKD diagnosed, both before a child is born and after?
That's an excellent question. So the presentation is, and as you know, in the United States, the with good prenatal care, there's 2 times that a pregnant woman who is not a high risk get an ultrasound. Number one is if there's no uh, 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 the menstrual period is not there, and the woman and the couple says the woman suspect that she's pregnant, she will have a pregnancy test that positive. She have an appointment with an obstetrician, doing an ultrasound between 6 and 8 weeks of the gestation, and this is where you can confirm pregnancy. Then later on, if everything is fine, there's no complication, the other ultrasound usually between 18 and 20 weeks gestation. So if you have a severe presentation of prenatal ARPKD by 18 and 20 weeks gestation ultrasound, you will be able to see large kidneys, bright kidneys. You may not see cysts in these kidneys. It's hard to see cysts on an ultrasound in a baby, but and also if you have severe conditions, severe polycystic kidney disease, sometimes the unfortunate news tell the family is, or the mom, that you don't have any fluid around the baby. There's no fluid around the baby, which is very highly suggestive of a severe form of ARPKD. Now, some pregnancy can go, they can have a normal amniotic fluid but large kidneys or bright kidneys, and usually the prognosis is better because the amniotic fluid was normal enough to make their lung developed. Now, this can be missed, not because the ultrasound missed it, just because the presentation won't happen before when the mom is pregnant. We have patient presented at age 2 or 3 of life with hypertension, like they have hypertension, or they presented with fever and they end up having an infection in their liver, and this is why they found to have large kidneys. Some children then present until adolescence. They have an episode of bleeding all of a sudden, and they found that they have a liver problem, or they develop to have hypertension. And as I mentioned before, there is a subset of patients they don't have the disease until their adulthood. These patients usually above 18, the majority of them in their 40s of age, and the presentation is mainly related to liver complications or the biliary duct complications. Retrospectively, they don't have any symptoms. The pregnancy went okay. They have a normal childhood. They don't have hypertension. But all of a sudden, after adulthood, they can present with this condition as well.
Okay.
So, yep. So
Uh,
as a pediatrician, yeah, go ahead.
no, please.
So
I
yeah,
didn't mean to interrupt.
so ARPKD, we're trying not to call it an infantile anymore because as mentioned, some few percentage of people can have an asymptomatic childhood.
Okay. Just so our audience understands,
Yes,
a prenatal ultrasound can detect an enlarged kidney in about 18 weeks after conception. Is that a true or a false statement?
that's a true statement. They
And
can
I'm
yes.
sorry, go ahead, doctor.
Yeah, that's a true statement. And usually where we're talking about the prenatal or the severe form of ARPKD.
Okay, and you used the term echogenic a couple of times in
Yes.
referring to how ARPKD can be detected in a pre-birth situation. When we're talking about echogenic, that shows up on the ultrasound as being more white
Yes.
than okay.
Yes. Usually if you look at the kidney ultrasound, I will say the kidney on the ultrasound will appear gray, some black areas, there's some white area. If you have an ARPKD, the autosomal recessive, the neonatal onset or the prenatal onset, the kidney will be large and it will be having more white color than the blood color or brighter than it should be. So
Okay.
large and bright kidneys plus minus cysts.
All right. Please explain how prenatal genetic testing, like chronic villus sampling or amniocentesis, can help to diagnose ARPKD.
And it's usually taken as samples of the amniotic fluid and running a sophisticated genetic test on it. Sometimes can be missed, sometimes can be found, and you can test for the PKHD1 gene and other gene. Because it doesn't mean that if you see these findings on ultrasound that this is consistent with ARPKD. It's most likely consistent with ARPKD, but there's other genetic diseases can be mimicking the ARPKD, and the genetic testing sometimes, if it's negative, it can to a larger extent exclude the diagnosis of ARPKD. I just wanted to be clear that these findings on the prenatal ultrasound is usually suggestive of ARPKD, but to make a diagnosis, you have to do a genetic testing.
Okay. What's the difference between a direct search of the gene for mutations or an indirect association using linkage analysis?
So the direct gene is to look for the gene itself or to look for many genes that cause the condition. The linked analysis is if you have a family member with this gene and you need to look for that specific gene as well.
Okay. One of the things that surprised me when I was doing research for our discussion was the subject of pre-implantation genetic diagnosis, or what's referred to as PGD. Can you talk to us a little bit about how that process works?
Yes. So usually that work with ADPKD because one of the parents knows that they have the condition and they wanted to know if they can avoid having this condition into their offspring. Now with ARPKD, if there's no family history, which is there's no family history, and this is the first baby of the couple, they would not know to do the PGD because the disease is not known to the family. In ADPKD, if a parents or the mom or the dad are affected, that they can have the discussion with their with the pediatrician or with the obstetrician. With ARPKD, they have to have an affected child to make a decision with the other child, knowing that there is a 25% of the other child to be affected. So and let's talk about PGD. Is knowing the diagnosis, the genetic diagnosis of the embryo before implantation. So what happened is the woman has to go under an in vitro fertilization or an IVF to retrieve an egg from her and a sperm from her significant other, from her spouse, to make an embryo. And before they put the embryo into the uterus, they try to take 1 or 2 cells from that embryo, or after yes, and to see if they have a genetic mutation. Have to be done in a very rapid turnaround within few days, in order to complete that pregnancy. So that's usually happened to make the diagnosis of pre-implantations. Now, in order to do that, there's going to be an extensive discussion with the family member about the risk and the success rate of this this condition. We know that the success rate of pre-implantations or doing this procedures to have a successful pregnancy is about 50 to 70%. In the United States or in Europe as well. The other condition, and just to clarify, we're talking about the PGD and ARPKD, or we're talking ARPKD and ADPKD in general?
We're talking about ARPKD.
Yes. ARPKD, as you know, it's a condition that have more complication than ADPKD. So it can be a life-threatening disease, to have a consideration with the couple. The PGD is usually recommended to be considered in condition that's life-threatening, like ARPKD. Could be life-threatening, like you can have a neonatal without kidney with bad lungs, and that can be considered. It has to have a extensive discussion with the couple, with their obstetrician, the risk of doing this procedures, and the risk of losing pregnancy.
Okay. Is there a difference between the symptoms of ARPKD prenatal and the symptoms of ARPKD after the child is born?
So yes, the prenatal diagnosis, if there is an ARPKD that's diagnosed prenatally, the complication can be from needing of dialysis right after birth, to having some complication from ARPKD like hypertensions and some mild kidney failure until they progress to end-stage kidney disease later in life. Whereas if you don't have any symptoms of ARPKD prenatally, assuming the pregnant woman had a good prenatal care, that can manifest later in life, and usually the manifestation would be either a mild kidney disease, a mild liver disease, or it sometimes can be a severe liver disease. Children who survive childhood, and if this went underdiagnosed, some of them, they can have complication in the future related to the liver and not related to the kidney, which usually is not present at birth. The complication of ARPKD in terms of a liver disease usually is not present after birth, usually can present later in life.
Okay. Let's talk about where people can go to find support, where parents can go to find support. First of all, I want to tell everybody there are many, many links in the original comments to this broadcast where parents can find things about ARPKD, about doctor, about articles that have been written about him, his bio with the Mayo Clinic, other podcasts, broadcasts that he's done. One in particular stands out. Male Mom might be one that you want to check out. Also, there are a list of places through the PKD Foundation where parents have a child with AR-PKD can find support and resources. So if you're interested in that sort of thing, please check out the comments. Doctor, in your experience, where can parents of AR-PKD children go to find help or support?
As support of them as a couple or support for their children. So if support as a couple and meeting with other people, the PKD Foundation had that can be found in the PKD Foundation's website as well. Sometimes if we have families in our center with AR-PKD, we try to see if other family are interested to share their experience with them, bearing in mind that the course of the condition may not be identical between children, different children and different families. So we try to see if there's other group in our center that may be interested to talk to the family and provide support. We usually that's the case. And we try to have family reach out to foundation in PKD or a pediatric foundation in the United States as well.
Okay. One of the things that surprised me when I first read your article, and you have to remember your old Uncle Jim was diagnosed with PKD back in 1983, in ancient times.
Wow.
I was 42 years, Doc.
Yeah.
I was surprised to find your note that talked about autosomal dominant polycystic kidney disease being found in children. Can you talk to us a little bit about that?
Yes. So I just wanted to end the AR-PKD and just to summarize to the people, AR-PKD is a condition usually happen in children, could be severe, and some of them can present in adulthood. You have to have a gene problem in two both parents. So this is the autosomal recessive. The autosomal dominant polycystic kidney disease, which your Uncle Jim had it, and you were a young adult when you had that, and that led to a complication of kidney failure. And I'm glad you get your kidney transplant few years ago, and you're able to keep on with this podcast and be an active member and a voice for the ADPKD. So yes, and this is why autosomal dominant polycystic kidney disease used to be called the adult onset PKD. Now, it's true that's an adult an onset, but there are a small portion of people can present with very early onset ADPKD. That means they can have abnormal kidney ultrasound. I'm going to go back to the prenatal ultrasound. ADPKD can present prenatally. They can have large kidney. They can have issues after birth with hypertension, with kidney dysfunction. But the percentage is small, unlike the AR-PKD. The majority of them will present during adulthood. But the gene mutation occurred when the baby is born. The gene mutation is there prenatally. The gene mutation is there after birth, during childhood, until they develop symptoms, and usually during adulthood. And as we know, the 50% of the people with ADPKD present with end-stage kidney failure or kidney failure in their fifth or sixth decade, like around 55 years of age. So ADPKD, the autosomal dominant, is not an adult. There is a small number of patients and what we call the very early onset ADPKD present before 18 months of age, and even before they get before when the family are pregnant with them, when the mom is pregnant with them.
Okay, talk to us a little bit. Please explain.
Yes.
What is ADPKD? What does the dominant version of this disease look like?
Yeah. So the reason why it's called recessive, because you have to have gene in both parents. In ADPKD, the way we call it dominant is you only have one gene defect either from dad or mom, who are known to have ADPKD, and only one gene defect will make this disease dominant, because that gene defect is dominant compared to the other gene that the patient inherited from the unaffected father. So you only have to have one defective gene to cause the disease. Well, in autosomal recessive, you have to have two defective genes in the same child or in the same patient to have the condition. And this is what makes this disease more prominent, right, Uncle Jim? Because it's you only have to have one gene and one affected parents to give this to the children. Now, I just want to be more scientific. This has happened 90% of the time. Now, we've seen patients who are diagnosed with ADPKD at the age of 20, for example. None of their parents have it, none of their cousin, none of their uncle, nobody. And that's because that 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 patients, a male or a female, have that mutation when during in utero. So something happened in the gene, did not inherit the gene either from dad or mom, but have the gene mutation. The changes happen um, in utero when that person developed, and that happened in 10% of the cases. So 90% of the cases of ADPKD come from affected dad or mom, and with a strong family history, and 10% can happen what we call a de novo, or a new gene, and that person will be the first person to have that in the family. And again, the chance of transferring it to their offspring will be 50%, and so on. So this is how it can start. So
Okay, so
at some point in your family, maybe one of your family member, your grandfather, your great grandfather, probably start to have this mutation and start giving it to their children, uncle and cousin, and until you got it from one of your parents.
okay, if I understand what you're saying, if one parent has it, the dominant gene, and one
Yes.
parent does not, the chances of the child getting it are 50-50 approximately.
Yeah, 50%, 50%. Because the dominant gene in the dad, that's mean the dad who is affected. Let's say the father is affected with the gene. He has two chromosomes. One of this chromosome have the affected gene. The other one does not have to have it. And the dad has to transfer one of the chromosome to their child, either this one or this one. So what the chance of having either one of them is 50%. And regardless of what gene, what chromosome will come from the mom. So because it's dominant, if the dad gave the abnormal gene to the child and the mom gave any of her chromosome, the ADPKD will develop.
Okay. Um, in pediatric patients, is it common or uncommon for a child to be born with severe ADPKD, or is it more common for them to develop the symptoms in early childhood that slowly progress as you're going through adulthood?
Yeah. So very rarely to develop or to have a severe ADPKD. The diagnosis in childhood usually happened due to screening, like or incidental, or symptomatic from it. So let's talk about family screening. Family would like to know if their child have it, or if the children have it. So, and usually that will be an ongoing discussion with the provider: is do we need to screen our child or not? So this is a dilemma among nephrologists to happen. And the other options is the patient have an imaging studies of the abdomen for a different reason. Number one, abdominal pain. Number two, trauma. Sometimes if you have a trauma patient and they have abdominal pain, they do CT scan on ultrasound to see if there's bleeding, and this is where you can develop you can see the cyst. Or you have a back pain, non-specific and related to the kidneys, and sometimes you can have symptoms And usually the symptoms of ADPKD in childhood is usually they can present with finding of hypertension during their well child check, and if there's a family history of ADPKD, that's increased the suspicion that why your child have a hypertension. He's healthy, but your dad or mom have ADPKD. So let's check if you have ADPKD. Let's do the ultrasound, and boom, you have kidney with full of cysts, both sides. The hypertensions in children with ADPKD is around 20% of children with ADPKD. They have hypertension, so it's not common. It's 20%. It's not rare, but it's 20%. That's 1/5 of the patient. They can also have protein in the urine. Now, there's a lot of non-specific symptom retrospectively in children with ADPKD. They tend to urinate a lot. There's a study showed 50% of children with ADPKD, they have report waking up at night to urinate, or they urinate a lot and they drink a lot. And that has to do with their the PKD expression in their kidney and the able of kidney to concentrate the urine. Some of them can present with urinary tract infection, or they can present with the kidney stones. I had a patient present to me with infection of the kidney cyst. They present with abscess inside the cyst of their kidney during 12 or 13 years of age, and they found it on ultrasound. And the dad or mom have ADPKD, and that's how the diagnosis was made. So I think I wanted to summarize that ADPKD in children is usually asymptomatic. The symptoms usually start during early adulthood in 20 or 30s when they have developed hypertension. However, there is a small number of patients, very small number, less than 10%, let's say, they can have symptoms specific to ADPKD during childhood.
Okay, so if I understand what you're saying, most of the time, children that have the dominant version of PKD are asymptomatic during child. In other words, there are no symptoms, and that the symptoms usually don't present themselves or are detectable until you become a middle-aged adult. Like in my case, I was 58 before they definitively said, yeah, you know, we're seeing this now show up in more than just the simple X-ray. The other thing that complicates this is that ADPKD can be diagnosed or found in a fetus, an infant, a child, or an adolescent. Or do I have all those statements correct?
Yes, yes. So yes, ADPKD can be found in prenatally, and you can see again using the word echogenic or brighter kidney, you can have see 1 or 2 cysts of the kidney. So if I have a couple, one of them have ADPKD, and at 20 weeks gestation, there is or maybe later on, there was cyst in one kidney and the kidney are echogenic, that will make the diagnosis of ADPKD closer to 100%. But this is usually that's not the case, and cyst will develop later on. Now I have to be clear. I just wanted to be clear with the audience and to you, Uncle Jim, is do children who have ADPKD develop cyst? Yes. Do the majority of children who have ADPKD they have cyst? The answer is yes. If you did a CT scan and MRI on these patients who have the gene inherited from dad and mom, you will find cyst. The question is, are these cysts causing symptoms? The answer is no. What the cyst has to do to develop symptoms? The cysts have to grow, have to push the tissue around it in the kidney to cause pain, to cause hypertension, and to cause destruction of the kidney tissue. This is unusual to happen in children, but cysts can be found in children. So if I have a parents, they want their child to be screened for ADPKD, and we can discuss with them the pros and cons of screening their children. If we did an ultrasound in a child, either dad or mom have ADPKD, and we found one cyst that above 1 centimeter in that child, only one cyst on an ultrasound, that will make the diagnosis of ADPKD very likely.
Okay.
Very likely on an ultrasound.
You mentioned that ADPKD in children is normally discovered incidentally, or what your Uncle Jim would refer to as by accident,
By accident, yes.
with abdominal imaging, nonspecific
Symptom.
symptoms like nighttime urination, upper urinary tract infection, back pain, protein in the urine, screening family member finding that they are diagnosed with it. Um, what what kind of considerations do you go through in the screening of a child for ADPKD? What kind of discussions do you have with the parent
Yes.
of that child?
Yes. So parents, and I had as you know, in Mayo Clinic we have a lot of parents with PKD reach out to us asking if they need to screen their children, and I'm happy to talk to them on the phone or having a meeting with them. And this is how I approach it with the family. Is number one is does your child, I mean, just talking to them, does your child need to know about a condition that is asymptomatic? Is how the child will be receptive to about the diagnosis. So we try for all the children who have comprehensive and understand disease and complication, we try to involve them in the decision making to see if screening needs to be done or not. I don't recommend, just to be frank, I don't recommend screening to everybody. I think if a parent asks me, do I need to screen my child? I will tell them, does your child have high blood pressure? The answer is no. Does your child have any urine checked? If there is any protein in the urine, the answer is no. Does your child have any symptoms related to ADPKD? Does your child have any kidney stones or any urinary tract infection, which are non-specific signs of ADPKD, but could be with the positive family history, could be suggestive of ADPKD? The answer is no. I'll tell them there's no need to screen your child. Why there's no need to screen your child? Because there's no treatment in the United States and in Europe. There's no FDA in Europe. I don't know what they call the FDA in Europe, like the FDA of Europe. There's no approved treatment for ADPKD in children or a disease-modifying agent to the time that we're talking in this podcast, which is in October of 2022, because there's no disease-modifying treatment for ADPKD in children less than 18 years of age, and the child is asymptomatic. I don't usually recommend screening. The screening would be recommended if there is a treatment for children that we know that in an asymptomatic children who have PKD, this treatment will improve the survival rate of the survival of their kidney. Instead of having their kidney disease, we tell family 50% by age 55 or 58. Until the treatment can tell us that we can prolong the survival of the kidney until 60, 70, or 80, there's no need to do screening. That will be a burden to the family, burden to the child, um, anxiety. It can lead to anxiety. Now, if a child of a parents with ADPKD, they have hypertension or they have protein in the urine, I would recommend screening. I would recommend doing ultrasound, because studies have shown that this patient have hypertension, they have proteinuria. These are early signs of something happening with the kidney related to PKD. The cyst is getting bigger. Hypertension is not good for the heart. It's not good for the eyes. It's not good for other organs. We need to make the diagnosis. We need to control the blood pressure. We need to follow them very closely. Now, in the United States, there is a clinical trial for ADPKD that's ongoing, and that's for children age 12 and up and older. But we are not screening children to make them enroll in the study. We are only having an already established diagnosis in a children, like a children, we have the diagnosis on them, and there is a strict criteria for them to be enrolled. They have to have an abnormal kidney function, which is very rare to happen in pediatric ADPKD. So regarding the screening, just to summarize, I don't usually recommend screening in a asymptomatic child of a parents who either one of them have ADPKD, unless family insisted they wanted to know. We try to involve the child in the discussion, and if they wanted to do it, we can offer to them doing an ultrasound. Now, having a negative ultrasound in the child does not rule out ADPKD. If you find a cyst on the ultrasound, yes, the likelihood there is an ADPKD. The absence of cysts on the ultrasound in a child less than 18 years of age does not rule out ADPKD 100%. And that's family need to know about this as well.
Okay. I meant to ask this of you earlier. When we were off stage, you mentioned to me that you have just completed a study. The findings have not been published yet, but to get a little bit of a jump on us, can you tell us a little bit about the study that you've recently been involved in?
Um, that study, probably we're talking about the ARPKD. Is that correct, Uncle?
Correct.
Yeah. So and we have been looking at parents of children with ARPKD. The parents of children with ARPKD are asymptomatic carrier. And actually, in fact, some of parents can donate kidney to their children, and that kidney do just fine. We are finding that some of these parents, they can have cyst in their kidney or cyst in the liver. That is usually asymptomatic, usually don't lead to complications into a kidney failure, but they can have cyst in their kidneys. Now, we have people presented to us with kidney stones with cysts in their kidney of the liver, but there is no family history of ARPKD. And we found in their genetic mutation that they have one defective gene of PKHD1. So we are concluding that although the care of PKHD1 very unlikely to reach end-stage kidney disease, or they have this scary liver complication, they can present with cyst in their kidney, they can present with cyst in the liver, they can present with kidney stones. And we're finding that in some people who presented to our practice with these conditions. So
Great.
parents of children with ARPKD, they're usually asymptomatic, but they may have kidney cysts that are small, or they can have a liver cyst or kidney stones as a manifestation of their condition.
Okay. Getting back to the dominant version and children,
Yes,
it's my understanding there's no data to suggest that screening children before they have symptoms does anything to improve outcomes. Is that a fair statement?
that's fair statement. Yes, because
Okay.
there's no treatment for them that's approved.
Are there any preventative steps or actions that a child or his parents can take to help with ADPKD, even though right now there's no FDA treatment, there's no tolvaptan for children?
Okay.
Are there preventative steps that they can take?
Okay, so I think, and I'm gonna just divide this into a few different scenarios. Number one scenarios, parents with their child, we have a discussion, me and the parents and the child, and the decision is your child is asymptomatic. We don't need to screen. That does not mean your child don't have PKD, but I tell everybody to maintain normal lifestyle, weight weight management. Make sure that you stay fit. You avoid overweight or being in the obese category. Limit the salt in your water. I'm sorry. Limit the salt in your food. Drink a lot of water. Avoid smoking. Avoid illicit drug use. So this is an advocacy guidance we say to all children, not only with children with ADPKD. Now, if we have a child with ADPKD, we re-emphasize on these more and more. Like you have ADPKD, we would recommend you to have a regular visit with your primary care doctor, because 20% of children with ADPKD can present with hypertension that can be treatable. We would like you to have an annual test of your urine to detect any protein, which is an early signs of kidney involvement from ADPKD. We would like you to limit the amount of salt in your diet. As I tell other children, please limit the amount of salt of your diet because that's a risk factor of kidney stone, that's a risk factor of hypertension, even if you don't have ADPKD. Drink a lot of fluid, mainly from water. Be fit, do exercise, run, be a part of the sport group, and do well in school. So we try to reemphasize to them. I can tell you, the majority of patients that I see in our PKD are usually asymptomatic. A few number of patients, they have hypertension, protein in the urine, and they are on a blood pressure medications. We have children, very rarely that we see children who have chronic kidney disease or we have abnormal kidney function. And when we say about chronic kidney disease, their number is less than 60. You probably know about this very good, Jim. When you're ready for your dialysis, your number was closer to 15 or 10 probably, or 20 when they put you on dialysis. The normal is above 90, and this is the majority of children we see. Some of them can be in the 80s, but very rarely to have somebody less than 60 or even down to 15 or 10, which is end stage kidney disease. So we with children of family with ADPKD, we recommend lifestyle. With children who knows we know that they have ADPKD, we also recommend the same lifestyle. With we emphasize more about a close follow-up with their pediatrician and have an annual visit with a pediatric nephrologist or with their primary care doctor for blood pressure check.
Okay. So if a child has high blood pressure or protein in their urine,
Yes.
has a strong family history of ADPKD, and the parents decline screening at that point in time, what would your recommendation be?
Yes, and I think I would have to sit down with the family and discuss why they don't recommend screening. And number one, if this is, it will be difficult to, maybe the parents will be defensive if none of them has a family history of ADPKD. But if you have a parents who have an ADPKD, who have a brother who have ADPKD and dad who has ADPKD, and they know the course of their conditions, that some of them is on dialysis, other did not make it into a kidney transplant because of complication dialysis, that will make their decision easier to screen their child, to make the diagnosis and jump into the treatment. Now, it happens sometimes when parents, they don't want to screen their children. We try to discuss and find the reason why. We try to involve the child. Sometimes the child will knows that his dad is have the PKD, or the mom or the grandfather, and they know how sick some of their family member were, or how good they're doing other family member. They don't want to know about their conditions, and they don't want to make a decision, and we try to respect their autonomy. And that discussion can happen rarely, and I can tell you that few number of kids and their parents refuse to, or decided to hold off, not say refuse, decide to hold off on screening their children. Now, the big problem, if their child have hypertension, now we don't want it to screen your child have a hypertension, I could not find the cause. We need to treat the blood pressure, and I have to explain to them why controlling blood pressure in children is important. Hypertension of children is a risk factor of hypertension in adulthood, is a risk factor for early coronary artery disease or early cardiac disease, eye disease, and also hypertension by itself can give you kidney failure. Hypertension and diabetes are number two and one. Diabetes number one, hypertension number two for kidney failure in adult, regardless if you have ADPKD or not. So having an hypertension on top of ADPKD will make your disease progress faster than not having hypertension when you have ADPKD. So I do my best to explain to the parents, and usually the majority of time we are in a good term success to screen their children. Now, Jim, this rarely happens because usually parents approach us and they want to screen their children. And sometimes I tell them no. I try to convince him not to screen their children if they have normal blood pressure and protein in the urine. Once they have any suspicion of high blood pressure and protein in the urine, they already want to screen, and we try to screen. Some of them actually said, I want to screen my child even if they have asymptomatic. I try to tell them it may be a good idea, it may be not, and we ended up doing the ultrasound on their child and go with the results as well.
Okay. Let's talk about the use of talvaptan in children for a minute. It's my understanding that as far as pediatric approval for talvaptan is concerned, there's a trial that's ongoing for children ages 4 to 12 in Europe. The study is over, but the results remained unpublished. So there are challenges with that medication and children. Can you discuss that with us a little bit?
Yes, yes. I just wanted to clarify. It's actually between age 4 and 17. So
17.
not
Okay.
yeah. So yes, I think the study is trying to study the how tolerable is the medication and how effective is this medication. And let me ask you, and sorry for my ignorance, you have not been on this medication because it was
No.
FDA approved after you receive your kidney transplant, and you're not
Correct.
part of any studies about this medication. Is that correct?
That's correct.
So tolvaptan is a medications that is and I'm not going to go into the details because of the audience, but the tolvaptan have shown in an animal study and preclinical and a clinical study that it can slow the progression of PKD by slowing the growth of their kidney cysts. Now, not everybody who have ADPKD is eligible for that. Usually people who have moderate to severe form of ADPKD, which mean we know that you may develop kidney failure by this age, and we are going to give you tolvaptan to delay the onset of your end-stage kidney disease. As you know, some people with ADPKD, they can be mildly affected. That means they may not develop end-stage kidney disease until they're 70 or 80 years of age. But as you know, the majority do it when they're in their 50s. Now, these people, there's some imaging study that we do at Mayo Clinic, and we do other practice and tertiary medical center, that the condition is mild, the ADPKD in adults, so tolvaptan is not recommended for them because they already, the natural history of their disease is mild. So the tolvaptan, one of the side effects of the tolvaptan, it's a black box. It can have issues related to liver enzyme and increased liver enzyme. This is why people who take tolvaptan, they have to have a serial check of their liver enzyme, and there's a criteria when to stop the medication or when to continue this medication. Now, let's go to children. Why tolvaptan is not being widely used in children? Now, it's not FDA approved in the United States. One of the common side effects of tolvaptan, it's a side effect of tolvaptan. If you're not having it, that's mean you're not taking tolvaptan. The tolvaptan makes you urinate a lot. I've seen parents having a bottle of water, they drink 7 liter, let's say 7 liter is 2 gallon of urine a day, 2 gallon of urine a day. I mean, a normal person maybe pee half a gallon per day, like between 1 to 2 liter. So now you're peeing 4 times the amount. And in order, if you're peeing that amount, if you're not drinking the same amount, will be dehydrated. So imagine a child taking tolvaptan, asking to drink up to 3 or 4 liter, like double or triple the amount of fluid, and they may stop taking the medication. I mean, I can tell you, if they're taking the medication, they have to drink. If they're not drinking, they can have complications from urinating and dehydration, electrolyte abnormality. And we're looking forward into the result of this study Now, I'm anticipating maybe teenager are more tolerable of this medication rather than small children, because imagine a 4 or 5 year old will be able to tolerate tolvaptan and keep up with fluid intake. The other question is, what if this medication in the future need to be tried for babies or infants? They're not going to be able to have a bottle of water around them, so we have to feed them ourselves, or maybe putting a G tube to feed them. So we're looking for is the tolvaptan is tolerable for children? Can they take it without affecting, without, can they take it and drink fluid? Is there's any concern about their liver enzyme? That's number one. Let's say no problem on the liver in the majority of the patient or in almost all of them, and they're able to drink. The question number two, is it effective? That's mean, is it slowing the growth of their cyst in their kidney? What happened after 1 year or 2 years of taking the medication compared to children with the same age, matched with sex and age, who are not taking the tolvaptan? If there's any difference. If there's no difference, then why do we have to put the child on a medication that have risk of their liver and risk of them peeing a lot? Now, that's why we're looking forward. I'm just talking as a the result may surprise us. The result may be that tolerable medications have a good effect, which means good. Let's put the majority of our patient on it, and let's prevent their disease progression as early as possible. So we're looking forward to see the result of tolvaptan in Europe, from the European. Personally, if I have parents ask me, should we put our child on tolvaptan? I mean, I will tell them, I would not recommend it. Number one, it's not FDA approved, and number two, about the side effect, and number three, let's wait for the research trial, and hopefully we can do a trial in the United States if the trial in Europe was positive, which means favorable result from using the tolvaptan.
Okay, let's talk about some of the other ongoing research at Mayo's that involves pediatric patients. I understand there's some going on with biomarkers and medications for children. Can you tell us a little bit about that?
Yes, and I wanna just give some background. I already talked about it. ADPKD in children is asymptomatic. The majority of children, they have, let's say an adult or children, if they wanted to know the condition, they have the G mutation, they will have a normal size or large kidney that's full of cyst. And usually they have a normal kidney function, as we discussed. Now, the big question is, which child we would know they will develop a progressive disease, and which child will develop a mild disease, which mean which child can be benefit from early intervention with a safe medication, tolvaptan or other medication in the pipeline, and which child does not need the medication because the anticipation of their kidney progression would be mild. This is why, and nobody knows the answer. Nobody knows the answer. Can we identify biomarker in children? Now, there's a biomarker in adult. Age, sex, smoking history, the type of gene. There's an imaging biomarker, which we call the Mayo Clinic classification, which is approved for age 15 and above. We do an ultrasound or an MRI, actually, or CT scan of your kidney, and we can classify your kidney from 1A, which is mild, to 1E, which is severe. And we can tell the parents you have 1E, the likelihood that you're going to end up with end-stage kidney disease sooner than a child or an adult who have a 1A. 1A is a mild on the Mayo Clinic classification and MRI, and 1E is severe. We don't have that in children. We have it for 15 and above, but the number of children that enrolled in this trial, 15, 18, was small. What about the 13, the 12, the 8 years old? And we're trying to develop imaging biomarkers in Europe. There's a group in Europe that work in imaging biomarkers. We're trying to look at biomarkers in the urine. We're trying to look at biomarkers in their gene. Is it the only gene that causes the PKD, or is other genes that can be making this disease less progressive or more progressive? So as you know, the ADPKD is caused by PKD1, which you probably had, or the PKD2, which is the milder form. So we're assuming that everybody who has this the complication of PKD in childhood and in early adulthood, they have the PKD1 gene. But the PKD1 gene may be surrounded with other gene, or the expression of the gene in one person could be different than the other person, depending on what's happening around the gene, or how the gene is translated into a protein, and what's the dose of this gene, what we call a dose of the gene every patient. So this is something that we're doing here at Mayo Clinic with other centers, looking at biomarker for children that can tell us who is a rapid progressor versus a slow progressor. And in order to develop a high impact clinical trial on these children, and in terms of finding medication that's safe, that's tolerable, number one, and also slow the progression of their kidney disease. So we're enrolling patients at Mayo Clinic to collect their blood and urine, and to look for these biomarkers as well.
Okay.
Yep.
Before we conclude our conversation for the evening, Christian, is there anything else that you would like to discuss before we wind up our conversation? Is there anything I forgot to ask you about, or anything that you feel that you want our audience to know about?
Yes, I just wanted to, and this is something I wanted just to summarize and emphasize, that ARPKD happen mainly during childhood. Some people can survive and they don't have the manifestation until later adulthood, whereas ADPKD, it's a silent disease in childhood, very small portion that can have a severe disease after birth. The majority of them, they will not have the disease manifestation afterward. This is why I try to avoid the use of the adult onset or an infantile onset, because it's a spectrum. And at the moment, ADPKD happen in our children. 20% of them, they have a complication of it, like a hypertension, protein of the urine. And these patients, in my opinion, need to be identified, need to be treated, and with the assumption that treating them early would prevent the progression of their kidney disease. And also, we are looking into a safe medication that, if we give it to our children's, that would prolong the life of their kidney. But at the moment, we're still early in this road. It's a long road, and clinical trial support from foundation, having active people like you, Jim, reaching out to family, having a friendly discussion, have people come to your show, is helpful to spread the word about the ADPKD and ARPKD as well.
Wow. Dr. Hanna, I thank you so much for taking time to come in tonight and talk to us, raise awareness and educate us about so many things that involve children with PKD and their parents. I kept you overtime tonight a little bit. I apologize for that.
Thank you.
Just too many interesting the subjects to discuss. So I've got a little closing up I've got to do with the audience. I'm going to let you go because I know you're a busy guy. And I just want to say again, thank you so much for coming on to talk to us and educate us about PKD in children.
Thank you, Jim, and take care of yourself.
I'll do my best.
Thank you. Bye-bye.
All right. You have a good night, Doctor.
Thank you.
All right, everybody. That concludes our broadcast for this evening. As you know, I've got people lined up until the first of the year. I won't take up any more of your time tonight. Watch the space, and we'll be talking to you soon. You have a good evening. Bye-bye.